worth a debate. I think the debate has been created by the CPAC classification, and it was never worth the debate before that. So next slide, please. This way.
I think Havel started it.
Yeah. So the case is very simple, straightforward, 62-year-old female, all the frills and fancies of hypertension, hypothyroid, dyslipidemia, some amount of psychiatric issues. Bilateral OA with almost 30 degrees varus and 10 degrees FFD, right and left knee respectively. So now the choice was left. Nowadays it's not with surgeon, they ask for a technology assisted TKR, and that's what the psychiatric illness mentioned here says, that, right? So they wanted a technology assisted TKR. And this was the gait, pre-op walking, which is hardly of any, we have seen all of these so many times. The knee doesn't move at all. And this was the alignment, and this is the type of knee.
So I hope you didn't label her psychiatric because she asked for a...
I think so.
You did?
because no, it was there, but I was quite sure that...
I thought she was intelligent.
Yeah. So this was the standard joint which we get, and I would not have personally done technology assisted, but that's what we did. And this was the kind of mechanical, the knees were actually going out of the scanograms. So what are the first thoughts if we want to start?
Okay, Vaibhav, you can start again. Would you answer all of those?
No.
Quickly, one answer. Yes, no, alignment.
I mean, what's the question? I mean, we have to obviously do a knee replacement. I'll use technology. My alignment will be a functional alignment, and my achieved goal will be a high survivorship and high forgotten joint score.
Tejas?
Achieve goal on alignment?
Alignment, that's what he means.
So functional alignment.
Yeah. So I think it's...
So, but you must state your boundaries, 3 degrees?
So individual component up to 3 degree varus for this case, and overall HK deviation not beyond 5 degrees. And rotation, 5 degree external rotation at most, instead of 3 degrees.
Tejas?
I think almost the same. 3 degrees is my limit for the individual components, and maybe 3 to 5 degrees for whole HK.
Harsimran, again.
I'll use what I use for all patients, that is a navigation or a robotic system, and desired alignment will be determined by what is the constitutional alignment that I'm seeing on the screen.
Okay, Parag?
So first thought is this is a regular bread and butter case, no technology use, alignment mechanical, but I will cheat, use the word inverted commas, cheat, because might go to adjusted mechanical, and the goal is to give her a good result.
I agree absolutely. I don't use any kind of technology yet. Desired alignment is probably adjusted mechanical alignment, and the chief goal is, of course, good knee.
Ashok, same?
Exact same, ensuring stability through the entire arc of movements.
Amar?
My first thoughts are, I don't care what alignment you use. If you put in the implants and they're well fixed, you will make this person better. That's all that matters.
But you have to start off somewhere.
So for the kinematic alignment, like, do you vary as per the weight of the patient, or you're fine with whatever patient weight is, going for kinematic alignment also?
The restrictions are more harsher if it is a poor bone stock, or if the patient is very old, or if the BMI is very high.
So Harsimran, you have a limit, right, as to how many, and if you are not able to balance on your screen, what do you do then?
On the screen,
so how do you decide
I do a modified measured resection. So in this particular case, if the LDFA, primary LDFA is say 4 degrees, I would maybe reduce it to 2 degrees. And if the varus MPTA is say 5 or 6 degrees, I'll reduce it to again 1 to 2 degrees.
And it is still not balanced. Then? So anyway, I think let's go on and see what you did.
Because I went with the mechanical alignment, the technology was used, and this is what the images were telling us. We did have, I just dialed in a 0.5 degree flexion just to make sure my notch doesn't happen. And That's what the, coronal views were. And this is what we got. We never got actually 0-0. It doesn't come to 0-0. It always, even with technology, it comes to an outlier. And that's what the whole understanding of using technology in order to, even if you make sure you want to do a mechanical, it doesn't really come to 0-0 most of the
I
times.
think here, you're right that you might not have, but on your X-rays may not be absolutely perfect to measure the
Yes,
long alignment, because
yes.
particularly the right side.
Yeah.
And if you look at your tibia on the right, does anyone
Yeah,
think that
that-
that's not mechanically 90 degrees to the...
Yes, it's not that X-ray is not this thing. But what...
Then
what,
you should say that I kinematically aligned the right. And
no.
That is what makes
It
sense.
was a mechanical alignment which turned into a kinematic alignment. It became a functional alignment basically.
Mechanical kinematic function.
So the conundrum, the whole, so if I am permitted to go to the next slide.
Yes, please.
So she seems to be pretty happy with what happened. At 4 weeks, she seemed to be all right. And then, therefore, we desire an alignment, but even technology sometimes fails to deliver the exact alignment.
So
we land up with functional alignment, which is somewhere between the mechanical and kinematic. And patients are not bothered as long as they are pain-free and have a decent survivorship.
So I think from the technology not being able to give you that, I think one of the point which was made either this panel or earlier, that you should be using it for all your cases to get better at that. If you put a wrong anatomy in the computer, that's going to guide you wrongly. Also, you need to verify the cuts that you've made, if various things,
It's there, a part of technology. The verification is there always when you are doing the surgery.
So I think
it's always there.
technology, ultimately it is the surgeon. Okay.